So welcome everyone, and thank you for being here specifically on a Saturday evening to be supporting the community. So this is case discussion. This is third in the series today that we have. And so essentially somewhere or the other, we do practice something which is similar, if not very same as pediatric SLPs. Nevertheless, we add years to our own experience by listening to our colleagues, discussing with our colleagues and seniors. So here we are because we all do practice the science that we have learned, and we do try applying it as as an art when we are working with the kids. So it definitely helps to be listening. It helps us to reevaluate as well as take fresh perspectives in our own work. So, so today we have. I'm extremely happy to say this. And today we have Dr. Namita Joshi and Ms. Maitri Sahasrabuddhe with us to discussing their cases. So we'll start with introducing Dr. Namita. Ma'am, I am stopping the share. Please share from your end.
Okay. So this is the topic, and
So, Namita ma'am, born and brought up in Nagpur and has finished her post-graduation from Aish, Mysore. She has done her PhD SLP from BBDU SASLP, Pune. She's the director at Sampark-ePolyclinic in Pune and has a work experience of 21 years. Her special interest lies in professional voice users. She's currently the General Secretary of ISHA, and she's also the author of Marathi book on voice culture and articulation drill books in Marathi. She also on book on pre-reading and writing skills in children with HI. She's a former theater artist and a mom of two. So welcome, Namita ma'am. And I also would want to show you if my screen is visible. Can you
yeah.
stop share for just a second, ma'am? I have my hands on what ma'am has created. So I have these two books with me. I use them quite regularly, and the Marathi, the Devanagari script is very useful. We were discussing about this in the last talk as well. Just wanted to share the brilliance that you are in presence of. So thank you so much, ma'am, for accepting this. I really thank you so much. And over to you, ma'am, please.
Thank you. Thank you so much. I'll share my screen again.
Yes, yes.
So yeah, is it visible? Let me.
Yes, ma'am. Yes, ma'am. Totally.
Okay, so this is our team Sampark with two branches in Pune. One is Tapras branch and one is Kothur branch. And we are happy to share that our third branch is coming soon. Okay, so let's start with the video. I want you to all see some videos and then we are going to discuss about the case studies. Okay. So video is seen. No, video is not seen yet.
No, ma'am. The slide is still being seen.
Okay. It's an old video.
Okay.
And
now it's okay, ma'am. Now it is visible.
Yeah. Permission is taken from the parents to share, and it's an old video.
तू हुबळीला गेली होती ना? हा, मग हुबळीला काय काय केलं दीदीला सांग बरं. बाबासोबत पण मी जेव्हा हुबळीला होते तेव्हा बाबा जेव्हा ऑफिसला जात होता ना, मग आहे ना एक पालावाली तर त्याला पकडलं. कोणाला पकडलं? झाडा माणूसला. ओके. तेव्हा मी ओ कसं काय? ओके, मग काय बाप्पा डॉक्टरकडे जाऊन तेव्हा आजी आली होती. मग बाबाने चुकलं होतं माझा. मग आम्ही आलो. मग आहे काय सांगितलं बाबाला काय काय झालं होतं ते बाबाला सगळे
Okay.
सांगितलं
So you can see the first, this was the first video, right? And now I'll be moving on to share the second video. Okay. So remember this particular video because we are going to discuss about this. Okay. So even if you didn't understand, if you don't understand what she's articulating properly, but at least concept wise, you would remember what was happening in the session, right? And then this is the video where another time the therapist is trying to talk. This is the response.
I can't hear anything, ma'am. There's no audio to it.
Sorry.
Ah.
I think now it is.
No, ma'am. It is still the movement of the child that is being seen.
Okay.
Yeah,
Just a second. Just a second.
Ma'am. No problem.
Now it's okay?
No, ma'am. We are still on the slide.
Yeah. So this was the reaction of a child. A hand. Or what is it on? Another reaction. He look here and put it in the box. This was another reaction. And this is another video where the little older child was seen. Okay. I think this is also an old video. I think again the same thing will happen, that I'll have to stop sharing and share again.
Yes.
This boy got failed and this boy got 100 out of 100. So with which boy you will study?
With his.
With the failed one?
Yes.
But you won't get anything, na? How will you study?
Yes.
So you will study with him. So that means you're a little selfish. You're not studying, you're not helping him.
Yes,
you told that you will help him.
Yes,
no, you have to choose one option.
Yes.
This one? Huh? Pakka.
Yes.
Why don't you study with both of them?
Yes.
That should be the answer. You can.
First, I will give you a suggestion.
Okay. So you saw both the videos, right? Now I'll move on to again my screen sharing options. 1 second. So you saw 3 children right now. One was the child who was talking about some incidents. She had been to holiday and she was narrating that incident. You saw another child who was responding behaviorally to the task given. Both the children had behavioral responses to the task given and they were obviously not verbal. And the third child who was confused between the situation of what to do, right? And he was just going along with the therapist like, I'll do that. I'll do this. He was not really decisive, or he was not really thinking about the situation given to him. So earlier task, if you had seen the sheet properly, he was supposed to read the sentence and match the picture. So each picture, there were 3 sentences given and he had to match the picture to one of the sentences given. That was the earlier task. And then the therapist was asking, okay, which one do you think is proper? Will you study with the child who has failed and will you study with the child who is a topper? So child was not able to answer properly about that question and he was just saying, ha. So these are the 3 different types of children I've shown you. Now moving on to our topic. So what is definitely what we have come to just now see, what we have just seen is kind of, children who had delayed speech and language, children who spoke late, children who had history of expressive language issues, children who had definitely history of little or very negligible, behavioral issues, definitely social interaction and communication issues, not able to answer properly, not able to frame the sentence properly, not able to maintain the topic, So this particular circle, which is social pragmatic communication disorder, is what we are going to do today. And what is the difference between the SPD, or we now call it as SPCD, according to DSM-5 criteria, which is social in bracket pragmatic communication disorder. It is generally categorized under communication disorders of neurodevelopmental types. But nowadays, the surprising factor is all these children which I showed you, who were talking, who were verbal, did not have any neurodevelopmental aspects. Okay, they did not have any history of any neurodevelopmental or prenatal, postnatal, perinatal aspects to their history. Okay, so this is what is coming up as another entity or new entity, I would say, where it is mainly because of the social impact of the pandemic, and the parent did not know how to behave in the pandemic, or there was little or negligible social contact. I have seen parents putting the children 8 hours of screen time per day. Okay, 8 hours of screen time to a toddler. So eating, sleeping, going out is negligible, and even the parents did not know how to interact, you know. So they would start teaching ABCD even before the child asking for the needs. The child would know A to Z even before asking for water or asking for food. That is how we have now. I have seen these children from when they were toddler age, and they have reached to this level. So what do we see in red are the ones we actually see in the semantic pragmatic or social pragmatic communication disorder. We see copying phrases, non-meaningful chatter, poor language processing, poor turn taking, poor maintenance of topic, lot of social difficulties, not knowing how to interact with the peer group or anybody else. You could see the child was verbal, chatterbox, chatter, chatter, chatter. But there was nothing which she was able to socially communicate per se, unless and otherwise specifically ask is stay on topic, you know. So difficulty responding to questions, WH questions, and also talks around subjects are very poor. They cannot maintain the topic. It's mostly sounds like jargon to somebody who is not knowing the situation. Okay. So that is the red marker ones are the main symptoms of SPCD. And the other symptoms which are also, these symptoms are also present in children with autism spectrum disorder of variant type. Okay. So we have to remember that semantic neologisms or semantic paraphasias are more observed in the child with SPCD than those of autism. Or children with autism have more of language deficits, like language deficits to a severe extent. And you can say that it's a continuum for, you know, children who are specified coming today to clinic with autism spectrum disorder. They slowly come down to a social pragmatic disorder, and then they actually can get rid of their overall social anxiety. This is what the trend we have seen in the clinic. So complex and stressful situation for families, because most of the time the child is talking, you know, child is verbal, child knows. That is what is the impression. So noticing and developing concerns, there's discussing concerns, you talk with the friends, you talk to others, you take the diagnosis from the doctor. Many a times the doctor, pediatrician says that everything is okay, the child is talking, it's a little bit of attention issue, you put him for, you know, sports, or you put him for some activity or do some activities with the child, and child will be fine. But then this is losing the time. We are losing a lot of time in it. And then the child actually starts having a lot of issues with the phonological skills, phonological processing. It is now turning into the reading, writing issue. And then he or she is brought to the clinic. Okay, so that is what is happening. So something is wrong, everything is fine, that discussion is on, and confusion is still there. So when they come to clinic, we definitely tend to do autism ruling out, right? We have a lot of skills and checklists to rule out autism. So we do either of it and try to rule out autism. Definitely, we want to, you know, do pragmatic checklists, which are used in common clinics. You can use, there are a lot of online checklists also. So the first common one, which I've just put it, it's just a 10-pointer or 12-pointer, where you can just do it with the case history. And then if you find there is a delay or a problem, then you can do the detailed pragmatic profile checklist in preschool and school-going children. Okay, so that is how we usually do it. We follow receptive expressive language, you know, assessment, social quotient assessment, and pragmatic profile assessment. And if at all there is any phonological issue or any expressive language delay or articulation issue, we then move on and deal with those as well. So what to observe while doing the assessment in children? So intelligibility and fluency. So ask the child to tell small stories because the child is verbal. There is a lot of verbose. Ask the sound clarity and fluency. Ask about talking logical information. Like, does he have any logic in talking? Whether he talks in a over precise manner, or he talks in a very keyword approach, or he talks in a very specific common phrasing, copying phrasing manner. Like they usually have these copying phrases from the adult talk. So see whether they have these copying phrases. Conversational and social relationships are not very good with the peers or adults who are there, and they tend to express through a different type of communication. Like for example, the case I'm presenting today is very good at expressing through drawing. Okay, she expresses beautifully the incidences through drawing, but she's not able to express it through verbal mode. She just talks and she's not able to express what she actually wants to say. So irrelevant talks is what their characteristic features. Actually, you can pinpoint it in the first case history itself. So therapeutic intervention, definitely we work on speech language simulation, vocabulary, parent interaction. Basically, parent interaction is the one which probably is not solving the parents are stuck, they don't know how to communicate. They keep on correcting the child. Agar need bol, agar tu काय बोलतेस, agar तुला कळत नाही. A lot of negative talks are there around because the child has jargon or irrelevant talks. Okay, sometimes there is hitting, sometimes there is lot of negativity in the house of these children. Screen time is one of the, again, very much involved in their life. That is what we have noticed, that even though they do not watch it like 8 hours, but they're definitely minimal. When we ask the parent, they say, okay, minimal hai. How much minimal? 2-3 hours per day. Okay, that is what the minimal is about. So you can imagine it is definitely more than that in the house when they tell you 2-3 hours. Syntax and social skill training in the group is very much required. It's not individual. Individual training will not help them. Communication, interest, developing activities should be taken in the session. That is what we recommend. So case presentation, this case was particularly handled by my therapist, Shruti Bilwadkar, in the Sampark team. I'm just presenting the case. So you can see the child was brought to us by 5.5 years of age. And this is a very recent case, last couple of days case. When I spoke with Devasmita, the case had just appeared. So then we decided to take up this topic. And we have had many cases, which videos I'm already showing you. So 5.5 years, you can see the expressive language delay, social communication delay is seen. The red com deal is showing you the age in actuals. This is the gap in the expressive language, receptive language, social and communication skills. This is what we actually assess as a, dynamic evaluations at our clinic, where we check about gross and fine in actuals, cognition in actuals. So we take these cards and we check whether the child is able to do. So if you can see, in 5 to 8 years of the checklist in the clinic, she could hardly do 50% of 5 years. Okay, and she had not been exposed to the academic language at all. She was not doing at all. Like she didn't know even the alphabets properly. Narration was not there. Spelling, rhyme, reading and writing was very, very poor. Copying skill though was present. She could copy the alphabets, but not write. She was not able to do even cognitive skills completely. Higher language also very basic and very just 3-letter word in the comprehension was emerging, which was okay for her age, but this is how her overall case history revealed. Then we moved on to doing the pragmatic profile, which was developed by Bilwadkar and Vaknis in 2022, where she showed that section 1, communication function was affected, interaction and conversation was affected, contextual variation was affected. So she definitely had below pragmatic scores of, below even 4 years of age. She was 5.5. She had score of pragmatics below 4 years of age. And I would want to show you a narration and a picture description task, which would give you the definite pragmatic profile delay concept.
हॅलो,
Hello.
कशी आहेस?
मी 2 दिवस झाले आहे.
2 दिवस झाले. कशाला झाले 2 दिवस?
मम्माला पटते.
मम्माला
माझं पटते आज.
मम्माचा बर्थडे आज. ओके. आणि तू स्कूलला गेलेलीस का?
फुलं केली मी
काय केलं शाळेत जाऊन?
शाळेत जाऊन
काय केलंस?
शाळेत जाऊन मी करत केली फक्त
हो.
आहे ना
स्कूलमध्ये काय केलंस सांग ना.
फुल मध्ये मला पिकअप केले आहे.
पिकअप केलं. मग काय केलं?
आता मी डॉक्टरकडे आ करून बघती कान बघून बघती.
डॉक्टरांकडे गेलेली?
हम्म.
अच्छा. मग डॉक्टरांनी असं बघितलं का तुझ्या कानात?
हा.
ओके. आणि तू स्कूलमध्ये डब्बा घेऊन गेलेलीस का ग?
डब्बा नाही आहे.
टिफिन टिफिन
टिफिन नाही आहे.
नव्हता नेला टिफिन?
आज स्लेट आहे.
स्ट्रेट आहे?
स्लेट
स्लेट आहे?
स्लेट नाही
मग
स्लेट.
लेट आहे?
हा.
अच्छा. लेट झाली का शाळेत जायला?
हम्म.
ओके. आणि तुला फ्रेंड्स आहेत का ग? तुझ्या फ्रेंड्सची नावं सांग बरं मला.
माझी बहीण आहे ना ती दुसरी ना दुसरी आहे माझी. कावेरी फुल आहे माझी.
कावेरी?
हम्म.
कावेरी कोण आहे कावेरी?
मग ती दुसरी नाही
She told about Kaveri's
I
school now
know.
and asked about the friends.
मला.
So this is without picture description and this is with picture description where the improvement is drastic. Like same session after just 5 minutes when the picture was given, she had more clues.
मला सांग ग, या पिक्चर मध्ये तुला काय दिसतंय?
पिक्चरमध्ये
हं?
पिक्चरमध्ये ते मी आहे ना ती करत घेतली आहे पेन्सिलची.
ओके.
तिची ते ना ते कॉम्पस घेतली आहे.
Very good. येस. अजून
अजून बॅग घेतली.
बॅग घेतली का?
पाहिजे मला
पण बॅग घेतली का तिने?
बॅग घेतली नाहीये ती.
नाहीये. मग ती काय करते ग? काय करते?
ते ती म्हणती मम्मा बुक घेतीये.
मम्मा बुक घेतेय. ओके. कशी तयारी चालली आहे? तू हे असं सगळं घेतेस ना? कुठे घेऊन जातेस हे सगळं?
ते सगळी घेऊन चालली आहे.
कुठे?
मम्माचं एक पोत आहे कारण नाही येत.
तू रीड करतेस ते? येतंय तुला रीड
मला
करता?
वाटते काय आहे मला बॉटल पाहिजे तुला.
असं सांगते का ती? ओके. पण हे सगळं कुठे होतं ग असं?
So you now observe that it was much better with respect to the pictures. Like she was at least forming a grammatically correct sentence and she was talking relevant to what was in the picture. So this is what the difference tells you about when they are asked the narration versus picture description. So the pragmatic children with PP, pragmatic processing errors do little better with the picture. So this is what we have to assess simultaneously. So PAT was obviously done. Velas and retroflex sounds, migration was present, weak consonant deletion was present, fronting was present, cluster reduction was present at the age of 5.5. So she was definitely delay in the phonological processing errors as well. We did have ESA done. And then the scores definitely came poorer in social interaction and pragmatic, and rest of the scores were pretty much good. And she had total score of 49. So definitely below 70. So no autism was definitely given on ESA. Okay. So this was another confirmation that it was, more of a pragmatic and not moving on to the spectrum. Then we did sensory profile done by our occupational therapist Sakshi. And she also could see, you can see that most of this is overall, okay, overall scoring. So she is more of a seeker. Okay, but very little, like 20 was the cutoff and she had got 19. So very mild seeking issue, more of a auditory visual processing issue, but there was no touch, movement, body position and oral sensory issues, no seeking, no, avoiding. Even the behavioral issues were within the normal limits. So you can see here that occupational therapy reports are moreover like very, very mild case, okay, according to the OT, because she was able to do. But yes, when it came to higher language processing or sequencing of motor task, cognitive task, she was low. Okay, that is another sign where the sensory integration part will not be that affected except auditory and visual. Okay, because she has phonological processing obviously delay. So this is again, so we recommended her thrice a week of therapy, speech, OT and RT, and psychoeducational testing to rule out the social quotient, which was already done in her previous particular center, but we wanted to confirm it once more. So we have recommended this and she will be continuing. So what we need to remember as therapists or as, you know, counselors is when the pediatricians say, they say ASD or no speech therapy needed. So depending on if the child was very cranky during that pediatrician visit, they mark it behavioral issue, they mark it attention deficit, ADHD, or they mark it ASD, or they say no problem at all, she's speaking. So wait and watch, she'll be all right. So we have to sensitize them that this could be observed, storytelling, sequencing, you know, task of narration could be observed instead of just asking what is your school name, where is your, you know, school and who are in your house. Parents obviously, you know, do wait and watch. So we have to tell them that don't wait. If your child is not speaking till the age of 2, you have to come. Don't wait, because this is what is going to end up. You know, if you wait till 4 and the child is still not speaking, you might get something more. SLP goals and plans and group therapy definitely should be done with these children. Individual therapy will not sometimes work with these children. They may be doing excellent in individual goals, but they may be very poor in group therapy. So you have to adjust and observe in group as well as individual sessions. Obviously, children who have like articulation errors or phonological processing delays, so definitely some sessions of individuals can be given, but they will do better in the group therapy sessions. And allied professionals also should be done in group therapy. Like for example, occupational therapy and remedial therapy also will work beautifully in group rather than one-to-one sessions. So this is what we have to sensitize other professionals and doctors and parents as SLPs. So moving on to the take-home message, the pandemic has increased the sensory processing disorder-like symptoms without the neurodevelopmental history. Screen time, social distancing, no communication among the family and poor parent-child interaction has led to a lot of such issues, not only in semantic pragmatic, but even in other areas of language. Cartoon talk, parrot talk, unorganized thoughts, irrelevant context in talk. Identifying this semantic pragmatic disorder like symptoms in children is very much important. Though they are verbose, these issues can be asked, and sometimes children are smart. So in normal conversation and communication, you might not really know about this. So storytelling, sequencing, narration, all tasks are very much included in the children assessment as well while we are assessing. And it can completely be overcome if it is not neurodevelopmental. The children which I showed you earlier, they are now discharged from the therapy. The current child which I presented is still obviously going to come, but the earlier ones are higher communication or higher language skills, and the child who was talking irrelevantly about the hubri, they are now discharged from the clinic and they are doing very well in their normal education. So I can definitely vouch for that. If there is no neurodevelopmental or genetic issue, these symptoms can definitely overcome with the therapy right approach. Okay. So thank you, and thank you, Debasmita, for this opportunity. And I think I have tried to stick on time. So yeah, thank you so much, everyone, for patient listening, and I'm open to questions now.
Thank you, ma'am, for accepting this and showing us, because apart, like you said, apart from what the doctor says, there is so much of nitpicking we need to do. Ma'am, can you describe, like, because you said that you have discharged a few of these kids of some of the videos that you showed. Can you describe a particular session? Like, suppose, are you going to cue too much to keep them on track, or are you going to, how do you move from picture to a general talk about hi, how are you? Can you describe some working, like, ma'am?
If
Little bit for
if
our
I may, I have the intervention videos as well of few children.
Please do, ma'am. Please do. I
Yeah.
think we definitely can.
Yeah. So let me go back to the slides. Because I have like, you know, semantic pragmatic disorder and symptoms like children, we have a lot of children are coming to us, and it's been like years that we have been getting this. Oh, just a second. I'll just go to the slide where I have the videos. So it's very interesting. We have been fortunate enough to do one presentation with all pediatrics fraternity. So we had around 40 pediatric people, and I had presented similar case there. And that is how, I could pinpoint the very recent case to you and also have few old videos. Can you see my screen?
No, ma'am. It is end of slide. It is a black screen, ma'am.
You're not seeing my video slide, is it?
No, no, ma'am.
Just a second. So we usually do OT we do in group sessions. We do a lot of the child who has semantic pragmatic issue. We ask the child to now, is the slide open? My video slide?
Yes, ma'am. Yeah, the video slide is open. Yeah, the slide is visible.
So we do a lot of task where turn taking, suppose. So I'll just open this video. Let me know if you're seeing the video.
No, ma'am. We are back to your screen again.
Now?
Ha, ma'am. Yes, ma'am. Please. Yes, it's audible also.
The child who has semantic pragmatic issue, red color, he is guiding the child and instructing the child sequential task.
आता वरदा जाणार आरव तू धर तिला आरव तू धर वरदाला म्हण तिला.
Both of them had issues in sequential motor task and sequential.
Very good.
So this is one of the tasks where the occupational therapist was seeing that she had to instruct to the child to climb up by which leg, left or right, and then come to the next chair, again by which leg, next, left or right, then jump.
Correct.
So she was working on 2 to 3 sequential task commands given by a child who has semantic pragmatic delay. Okay, so this was one task. Then we had another task where the turn taking again was shared with the group session here. So these sessions are taken usually in the group. So you can see now another session where the group task is given and they are given the what comes next task. Okay. Are you able to see? I think I'll share again.
Yes, ma'am.
कोणाचा टर्न आहे?
Now it's okay, ma'am. And audible also.
व्हेरी गुड. मित कोणाचा टर्न आहे? व्हेरी गुड. आता सांग बरं हे काय आहे? काय आहे ते?
नेल कटर.
हँड आहे. हँडवर नेल्स आहे. काय केलं? नाही. न्यासा हेल्प कर बरं.
So he doesn't want NASA's help.
काय आहे ते? न्यासा तू सांग. हा, नेल्सला काय केलं? काय केलं? नेल कटरनी काय केलं न्यासा?
नेल कटरनी कट केलाय.
व्हेरी गुड. मितला सांग बरं.
So Meet was not very happy taking NASA's help and he didn't want to take help. Okay, he wanted to speak on his own and he was not able to frame that sentence, and NASA wanted to help but she did not know how to tell me to listen to me.
Correct.
He was just trying to poke his shoulder and he was not liking it. So these children definitely had this sharing, turn taking, and this is like much better version of them. Initially they would just make mess of the group sessions. Now they were waiting for each other's turn. NASA was though speaking in between, but she was still waiting to therapist to look at her and prompt, okay, now you help me, So that was so as I said in the session, we would do a lot of discussions, like the discussion was going on with the elder child, whether what will you do, what is right, what is wrong, what's wrong activities, then what is missing activities, what connects to the other activity. So what is missing in one activity, another activity, what will you do, what would have happened, you think, All these kind of questions. So imaginary questions when they go on a higher language, where if mama forgets the phone at home and the phone rings, what will you do? Such kind of questions for the higher kids. And the lower kids, it's still connecting, word association, visual perception, auditory visual combined perception. All those activities are done and they have fun. When it is a group session, they really have fun. They share, they take turns, and then slowly learn to say thank you, please help. All that also is learned very nicely in the group sessions, and you can see the pragmatic level increased really, really well in few months. Okay. So anything else you want to ask about the sessions, Debo?
Ma'am, how much of it was a struggle to convince or counsel, in whichever direction it went, the parents that it is not autism? Like, you have your checklist, you're showing them that, see, their cognitive level or their comprehension level or this thing. But did you have a parent who was believing it was autism and you told the opposite, or you had a parent who was not believing anything was wrong with my kid and you had to counsel in the other direction?
Yeah, it's a good question. So in the first case, where the pediatricians have diagnosed autism, and when I tell them that it is not autism, they are really, really happy. Okay. They really are happy. And they really sometimes open up with tears. Okay. Because they're so stressed because pediatricians
Absolutely.
or any other medical professional has diagnosed.
Correct.
Okay. In second incidences, yes, there are, as I said in the slides, those parents are more, because the child is verbal, does everything, so there is a disbelief. So when the pediatrician also has diagnosed, they also are not showing me sometimes that there is a diagnosis done. They lie that nothing has been done. We have come to you for the first time. And then obviously I am there in Pune since so long. So from somewhere I come to know that, they have gone and they have done. And then I tell them, okay, I know you've been here. It's okay. There is disbelief. And then slowly when the child starts progressing in a month time,
Correct.
you can see with picture and without picture. That is what I show them. See, if it was autism, this wouldn't have happened. Okay.
This drastic difference would not have been there.
In the same assessment session, it is
Correct.
really not so possible in autism. So then when I tell them with evidences, and I literally give them sometimes to read, okay, read this, whatever I've just shown you, read this. So then they believe, and then they are convinced and they come for therapy. So we have had sessions as long as 1 year also for some cases.
Okay. Thank you so much, ma'am. I don't see any more queries on the chat box. I think anybody wanting to connect with you, people know you, ma'am. So, ma'am, just wanted to show you this one thing. Ma'am, this is for you, and the screen is just loading. This is for you, ma'am. It's a very small token of love and appreciation for coming and sharing and updating us with this. Most of us see it. I think it has various different names on social media. Most of us see it, but the detail and the meticulousness with which you told us how to go about it was really wonderful. Thank you so much, ma'am.
Thank you so much. I hope you all enjoyed.
Yes, ma'am. Thank you. So we'll move on to our next speaker, and I'll just share my screen as well. One second. Okay. So I'll just wait for the screen to load before I. So our next speaker is Maitri Sahasrabuddhe, and so I've known her for long. So she is a speech language therapist and counselor with Communicare, and is presently attached as school counselor and developmental expert at Ramabai Paranjpe Bal Mandir since the last 12 years now. She has previously worked at KD and Shruti School, Juhu, Bai Wadia, Children's Hospital, Nanavati Hospital, and Children's Orthopedic Hospital at Hajili, now SRCC. She has pretty many other skills and trainings as well. She has an advanced training in rational emotive behavior therapy, the Robert Karkoff model of humanistic psychotherapy, and she holds a postgraduate diploma in child and adolescent psychology. Hence, you see her as a counselor in these places. She's also a founder member of Rehab Milestones, a company developing therapy material and education material. And she herself specializes in customized educational and therapy aids for both neurotypical and neurodiverse children and adolescents. And I'll just be stopping share for a second so that you guys can see my screen completely. And I want to show you what she has made. Okay, so she has created this for the MishaCon 2017, which was in Thane. She went in and out of her way for making this for her private circulation, and she included most of the audiology stuff as well. If you can see the type of tympanograms, the candidacy for CI, it's a 90-page ready reckoner. So just like with the previous speaker, I just want to highlight the kind of brilliance you are in today in the audience. So thank you so much for accepting this. I'll start sharing my screen again. And so, one second. So now over to you.
Thanks, Devasmita. It's wonderful to connect on the online thing after a long time again. Now again, we're back to an offline mode. So this is the slide I wanted to share. This is unconventional. I actually wanted to share this because I typically cannot go the typical way. That's my problem, I would say. And this particular child that I'm going to share with you all today, I kind of tried to handle it in a different way. So, Debu, you can go to the next slide, please. I hope you all can see this. Yeah. Anybody who has difficulty viewing this thing? I hope not. Okay. So this particular child, of course, his initials I have changed for the identity purpose. The thing is, he was born on 12th of April 2019, and he actually reported to me in October 2022. He was already 3 years and 6 months by this time. And he was referred to me by a leading developmental pediatrician in Mumbai with a clear diagnosis of being on the autism spectrum. So half of my job was already done. So just to give you the medical information, AM was born to parents at the age of 43 and 40. He was conceived via IVF, and the parents had 3 earlier failed IVF cycles. So both the parents had gone through tremendous physical and emotional trauma. He was born full term through cesarean, and he had low birth weight, so he had a NICU stay for about 1.5 months. And just poor latching since the day on, and he was always bottle fed. He was in NICU just for the sake because he was extremely weak. He didn't have any complications postnatal, but he was extremely weak, and his latching was really a concern for the parents. His motor milestones were delayed by about 5 to 6 months, and the pediatricians put it on the weakness that he had. Vocalizations were not really noticed. Babbling was noticed by the mother at the age of around 1 year. Unfortunately, father had succumbed to COVID and the related complications in September 2020 when the child was just a year and 5 months old. So obviously the mother went to a kind of shock and followed by a severe depression, and she was definitely not able to connect with the child. So not really, but she had kind of abandoned that child for some time. So this was really a trauma. So this child was born with a lot of weakness, and this happened to the whole family. And then he was looked after by his dadi and his bua. When the mother went into depression, later, because the family tried to kind of get the mother on the track, but eventually they realized that she needs a lot of help. So she was fortunate enough to have a good support from her brother's family. So she came to Mumbai, and they kind of started with her therapy. She needed a lot of pharma help as well, because there were times that she would not sleep for like days together, and the kid was always around. So it was definitely a very sad situation and nobody knew how to help her out. So when she came to me, this was the information given to me that he does not engage in any games and toys. The child had like cupboards full of toys, like puzzles and blocks and toy cars, but he would not even pick up any of that. He would always prefer to be indoors and needed to be pushed to play outside in the park. He would get petrified when he would step out. This was the kind of situation. He would avoid swings and slides, and he again in the park also he would just sit, and he would always wanted to get back home. He avoided peer interaction, and he always preferred to be with adults. This was the information given to me. And he was enrolled in a playgroup since he was since the age of 2.5 years, but he refused to be there because, as I said, he would refuse to step out of the house, be in a social situation, always wanted to cling to the pair, some adult around. So for 2 months, he really gave a hell of a time to the mother and the school management also, because he would howl. He would howl at the top of his voice, and he would just not be ready. But somehow the mother pushed through, and after 2 months, she was like gradually kind of trying to settle in the school. He's still in the same school. I mean, he was till he went back, because this family had come to me from not very rural area, I would say a city in Vidarbha district. Now he's gone back. And but later on, after 2 months of the mother pushing him and the school was being very, very cooperative, he was willing to be there. And while he was with me, he was willing to attend school. So could you go to the next slide, please, Jimmy? Uh, Meanwhile, I was picking up the information. It was also reported that the child reads storybooks. Now, imagine a child who comes to me at the age of 3.5 with very less verbal kind of communication. There was no communication. There was no nothing to talk about verbal or non-verbal. He was just there, like a typical, a kind of somebody who would just latch on to something. It was almost as good as not existing around. But the mother was very sure that he can read almost 80% of the children's simple storybooks. And when he would get stuck on a word, he would try to figure out the pronunciation. And this all she attributed to the skills because of child was watching reading videos. And he had picked up sight vocabulary from these videos, because like I said earlier, since the mother went into depression and she was struggling, kind of fighting her own battles, the rest of the family probably didn't know how to handle it. So he was kind of exposed to a lot of screen, like Dr. Namita mentioned, it was like 6 hours or sometimes even more than that. So probably the mother attributes this to his video exposure. Could you go to the next slide? This was a little, something little shocking, and I really couldn't fathom it at the first session itself. So he would use non-interactive through he would be non-interactive through the day. As I said, he was just there, somebody who was just there around. Like, the mother had described like a piece of furniture. He was just there. So they would pick up the times when they will think that he's hungry. He would not be reactive at all. He would just kind of cry once in a way. He would use some phrases or some basic words like mommy, water, biscuit, go out, on, mobile, falling, no, and absolutely no contextual thing. I mean, there was nothing. It was no need-based communication or anything. He would just do it. He would just do it for the heck of it kinds. And he was not toilet trained, and he was completely dependent for the activities of daily living. Yeah, could you go to the next slide, please? So, breaking the ice was the thing, and that is why I called it as non-conventional. This child would howl and roll on the floor as soon as the mother will get him near the clinic. And that was like, I had got complaints from, people around that what is exactly happening. And he would continue to do it till he was put back in the auto or the car he would come from. And this happened for 2 weeks, like 3 times a week. So it's like almost 6 times it happened. And the mother had almost given up because imagine, like, don't forget the background that she comes from, and then this. So every little thing would add up to her stress, and she would kind of immediately slide down. And since my clinic at that time was on the first floor, we were really in a fix. One thing that I had noticed, and the mother had very specifically kind of told me that this child is obsessed with numbers. He's obsessed with numbers to the core, that anywhere he would see the numbers, he would wait and kind of read them through. let that be a calendar, let that be a big kind of billboard or something. He would wait there, read, and then go ahead. So this was something that I used to get him to the clinic. We started placing the housey game plastic coins on the staircase, and he would start picking up and he would start climbing. So he, as soon as he would arrive, if he was to come at kind of 10 o'clock for the session, I would be right there at quarter to 10 placing this particular thing. So that is how we started getting him up. After 2 weeks of this howling, we figured it out that something needs to be done. So he was late, like again after 2 days, he was willing to pick up the coins and he would climb up, and but he would still not enter the clinic. He would just come there, stop, he would see the whole setup, and then it was again that we want to go back times. Then we had these dominoes made for him. You get these, we made it on the sunboard because the typical ones weren't really the ones that we wanted to use. So we used the ones, we repeated it because in the ready-made set, you get only one coin of that fixed thing. So we had these kind of arrangements. So we got them made. We got them made in different colors. So first you pick up blue, then you pick up the set of green, then you pick up the set of yellow. That is the way it would actually kind of, help him get into the room. So we spent about 4 weeks in getting this done, and he would be thrilled to do that. So like this, you see the journey after 4 weeks. He was finally in my room, just there without howling and crying. And we could see that the mother was little, she was developing some faith that, okay, this lady is not completely gone bonkers, because I never did any language test for him. There was no scope. There was practically no scope. So in between, when this was happening, I would call the mother once without the kid and get this history done, because it was impossible when the kid was around. So we had to figure it out that way. So she had developed some kind of a faith in our efforts, and she was like willing to come. There were chances that she could have given up, because she had already gone through so much and was going through. It was very natural for her to give up. But then we kept her pushing that, okay, we'll try something. And these tailor-made kind of, therapy aids really helped her build some faith in us. Could you go to the next slide, please? So initial sessions would get only 20 minutes, and they were all with numbers, exclusively numbers. There was nothing else happening in my session but just, arranging those dominoes or just having the coins on the floor and picking up. The child would pick up and bring them and put them on that, you get that board with that housey game where he would just arrange it. That was all the activity that we were doing for 20 minutes. And he would be refusing to change the activity, and he would reach bottom and then he would say, okay, that was his way. Once he would reach, he would go and stand next to the door. But that was a very, very positive expression, I would see, compared to that howling that used to happen earlier. That, okay, that was an indication that I'm like done with you and I want to step out, right? I would then request the mother to step in and she would read a book, and I would be just around. That he was okay, because I wanted to extend the period. Like from 20 minutes, we wanted to move on to half an hour or at least 45 minutes. So gradually we started doing that. The mother would come, she would read, and she would carry the favorite books that the child would repeatedly read at home. So she would do that. I would be just sitting there, and he was okay with that. He could tolerate my presence around, though he was bored with my activities. And he was very fond of flashcards also that the mother had mentioned. Eventually, he started getting, because after like about, as I said, I think a week or so of this, and 2 or 3 weeks of this kind of activity, we started having these number ka boxes in a toy cupboard, where next to the boxes of the numbers, there would be some other toys kept. Like one of them was a set of flashcards. And then he would, gradually at least try to see what is there in the other box. Initially, he would not even do that. But because then he was given a task, now that since you are here, you go and pick up the number ka dabba that you want. But next to that, these flashcards would be picked up. So it will be put up. So this child started picking up flashcards. And once he picked up the flashcards, as I said, he was good with reading. That was the mother had told us. So he would pick up the cards like, the vegetable flashcards and the fruits flashcards and the animals and the birds. He would read that thing. Could you go on to the next slide? Yeah. So he was already kind of reading, and he would see the picture and name that is lion and this and that. And he was already through that. That's what the mother told us, that don't waste time in doing that. He already knows all of this. That's what she would do. would tell us. So we started introducing the flashcards of community helpers and various other sports, the special vehicles, the kitchen utensils. This was the vocabulary which he was not exposed to, but he would see it around because he was watching videos. So all this he had an exposure to, and he would kind of flip through the books also, and he could even read as well. I had not still tackled kind of into that aspect of how much he can read and comprehend. My concern was how much he actually comprehends what he reads. But of course, these flashcards were very evident that he would just see the picture and he would read. He would actually say LION and he would say lion like that. Okay. So he thoroughly enjoyed reading and naming, but we moved on to the next category of vocabulary because his basic was really done by him. Next slide, please. So this was the task, as I told earlier, that he would refuse to touch any toys. Let that be even toy cars. Imagine a boy of like 3.5 years and not touching the car. I myself couldn't digest it because that is how the boys are so crazy about the cars. Usually that's what we have seen, and especially if the child is on the spectrum, I think that would be their kind of a toy of position that they would always like to have. So, and he would not even touch the toy animals or anything that's like a toy looking thing. He would not even go around that. So, we wanted to kind of go ahead and have a kind of interactive therapy. Like so far, if you have seen, none of these activities made him interact with me. They were like just passively, you do your job and I'm doing my job kind of a thing, and he was quite okay with that particular thing. But now I wanted to go a level further and kind of, help him have some engagement with some kind of a toys where I could take the therapy to another level. So what we would do, we would place the numbers cut from the calendar beneath the toy animals or the vehicles, and we would tell them, okay, below, like suppose there's a toy dinosaur, like a thing or a lion or something. You said if you pick up dinosaur, you will see a number. Would you pick up that number and place it here? And he was thrilled. By that means, at least he started touching it, and then he would say, dinosaur 29, lion 13. He would remember whatever that I would have put it down there. So next time we would, like if I put like 20, suppose 20 under the dinosaur, he would say no, 29 dinosaur. So I had to remember the sequence of which animal was, which number was below that particular thing. But then we started kind of changing. Oh, this time we had 20. We remember last time we had 29. So this is how we kind of changed that whole thing. So we would have these kind of, and the numbers were like a reward for him. He would be thrilled to see a number anywhere. So this is how we kind of extended to another vocabulary, like I said, using the flashcards of community helpers and everything. And this was another way where we could actually interact because he would pick up, look at me and say, no, 29, 20. I used to be ecstatic, oh, we have gone a level ahead. Like, at least he was acknowledging my presence in the whole of the situation. And he would know there would be somebody whom I can connect and share something. Okay. So by the end of 2.5 months of therapy, 2.5 months of therapy, I would say, he was able to sit through 30 minutes of session with tolerance to change of 3 activities. So from numbers, we moved to the toy animals, and one of it I could say was without numbers because he was over kind of bombarded with numbers. I would say I was not able to see the last line. I was Okay, so the visual schedule of activities, that was something that I needed to use with him, because he was so much into reading. We would write like the first game would be with numbers, suppose just arranging the coins or arranging the dominoes. The second activity would be with the toy animals, and the third activity could be something of the child's choice, but nothing to do with numbers probably, so that he would read through and we could go ahead with the sessions. Yeah. The next slide, please. Okay, so eventually we realized that this child definitely needs even occupational therapy because he had tremendous resistance to some kind of textures. He would every day wear a same set of t-shirts and shorts every day. Okay, and he would not even allow the mother to wash it because he would wear it like through the day. And she would always tell me to change him into a kind of a night dress. It would be a kind of a nightmare, because he would not. So then they had come to terms, she had to buy 2 sets similar looking. They didn't have to be like crisp new, they had to be used, So this child had a lot of those issues. And the mother would actually do everything just to kind of, reduce the kind of that howling that used to happen. And it was really, really bad. And you could actually see him getting tired after having an episode of crying, but he could not stop himself. So kind of, I wanted to introduce, start with the OT intervention also. And again, the mother was a little reluctant because one more person, he had just settled with me in the routine and everything. Fortunately, we have OT, like that time we had OT under the same roof, so we could help it. She was saying, no, let it be, I can manage this. I said, it's nothing to do with only the clothes. He has this kind of tactile sensitivity issues with most of the things. Like he would even refuse to eat anything which was wet and sticky. So no dal chawal or anything. He was living on kind of, something like papad and khakra or some kind of the bakery rusk that you get. Anything that's crunchy, little granulous, but he would be kind of surviving. No fruits around at all. So even that roti that she would actually make it like a khakra. It has to make some that crunchy sound while you eat it and when you break it. So gradually we kind of convince her that okay, this OT person would be just there in the sessions, like a passive person just around. And believe me, she was super cooperative. She still is super cooperative, and she would volunteer to step into my session and be there for around, just be around and not even interact with the child, not interact with me. She would be just there for about 3 sessions that she did, and she would observe and she kind of figured it out that how we should go about. After a month of trials, I'm specifying the timeline because this doesn't come like at the snap of the fingers, right? And this time, no crying. He was comfortable in the new routine. Like we started kind of getting him to the OT room, not taking him to the OT room again. We had to lay down, the numbers, and then we enter that place, and then we kind of go there and start doing. But as I said, the colleague is very, very cooperative, so she kind of helped me through. And like we said, we started with the OT, but then the child still had a limited time attention span. So we had scheduled it like only one therapy one day. Usually when both the therapies are under one roof, parents find it convenient to have it back to back. But for this particular child, we requested the mother that we will have only one therapy in a particular day. After he settles it out, then we can kind of have it. So it was there, and 4 months of beginning to see me, he had developed a great rap. Like there were times he would never hug because of the tactile issues, right? But he would just come and he would just give me that intense eye contact that okay, kind of I acknowledge your presence. And he had begun to use words and phrases spontaneously during the session. And even at home, the mother had said, please give. He would not say who, but he would just say. So he would refer to himself and would say sleep, mummy want, so and so turn, don't, open, open, take, more. These kind of, vocabulary was missing earlier, but she had started and he started using it more meaningfully. That is what the mother had. Because see, in the sessions, we actually couldn't go out of our box and do and venture out something because we always had that fear that the child would kind of, we lose him again. So the mother was experimenting at home. These things she had observed and kind of come and reported to us. Next slide, please. So as I said, that the reading was there in my mind through the day. I was still not convinced whether he comprehends what he reads. So the mother was super excited about it that he can read. This was one skill that her child had picked up earlier than the rest of the kids. So obviously the mother was very happy. But we being the therapist, we always see the other side of it. Ki samajh mein aa raha hai kya, So I was telling her that it's good if he reads, but I want to check that. So visual schedule from the pictures, we started moving on to know that the child is comprehending what he's doing. So I put it like reading a useful language modality for him to know whether the child is comprehending what he's reading. We started changing the visual schedule from pictures to the written strips. So and so would do this first, then he would do this, and then he would do this. And he would read through, and then we used to wait that okay, and we would arrange those activities right in front of him. Once he reads it, he was supposed to tap it and tell me this, and then this. He would not say it, but he would touch and tap. Okay. Started presenting him simple sequence cards. We old times I had bought that set of sequence card from the NIH Material Development Department, and we would show him the picture, let him have the story. Like I would arrange it. The child was still not able to do arrange it in a sequence. He would individually read it. Okay. No, this child had ice cream, now eating, now crying. So he would just use ice cream, eating, done. So he would not even say crying, he would say done. something like that would come. So we started writing these sentences and then make him arrange, like, okay, so the child has finished eating, or the ice cream is over, or the ice cream fell and the child is crying, is what the story is in the sequence card. But still, I was not convinced because this child had excellent visual memory. Like I mentioned earlier, if the dinosaur on the first session had 29 below it, it has to have 29 below it. So I was just trying to see that whether this child comprehends this particular thing, or he's just remembering it that as a sequence. So we started putting two stories at a time and then jumble up the strips and make him arrange it in a sequence. And thanks to really this child, he had patience to tolerate me at the end of the session, because I would not get convinced till he actually gave me the kind of response I would like to see. So he would first arrange the pictures in the sequence, and then below that, to help him, we started kind of giving him those picture strips. But out of those two story ka picture strips, he would pick up the right one and put it below that particular thing. So this child, I was using more of the reading modality for expression purpose, that okay, I would say, it was helping him out. At least he was coming closer to something which has language around and not completely with numbers kind of a thing. Could you go to the next slide, please? So like I said, the therapist, I think, is a very difficult population to get convinced in the first go. So we started giving him the written strip, like open the blue box and put the tiger inside. This was without any pictures, absolutely without any pictures. And if you say this particular phrase to him, this child would be completely like, I don't know what you're talking about. He needed to have that written thing in front. So the same thing I said, without the strip, no, nothing would happen. The moment the strip would come, and even if I just pretend to read, or I give it to him and like, okay, open the blue box, he would just read it aloud with a very, very clear articulation. This child uh, didn't have any phonological thing. He was talking clearly like an adult, even at the age of 3.6. Even like something like clusters, the br, the cr would come like Chris. So he would read through and do it. Finally, I was convinced that he can read and he can comprehend what he is reading, at least to this kind of a set, which was, of course, a closed set. We didn't kind of move on to the open set immediately, but he was able to read. To simple guess, so needed to take this ahead. So we started having games like Pictionary, kind of based on attributes. Like I would say that, I need something to cut a paper. I would use something to draw a picture. I would use this to eat noodles. And this child, and this I would say means I would read or give the child to read that strip. When I say, it's more of a reading, right? So the child would read. I need this to eat my noodles. So he would kind of pick up the word ka strip, a fork or a pair of scissors. So he would do that. So the moment you would take the strips away, there will be a blank face coming up here. So it was the way we did, and from the attributes of what, we went to where and then who. So we would give him a picture with a description, or we would write a question down, who is swimming, and then the child would say boy. Like he would pick up, sorry, I'm just saying it because it comes so naturally to us. The child would pick up the word boy. Who is jumping? The child would pick up that word and give me that thing, and where. So if the bird was there on the branch, so like on the branch, so the prepositions were coming in. The child was actually picking up those written strips. The next one, please. Okay, so eventually we wanted to make him, of course, independent with his ADL, because that was a big task for the Otis, and she was really trying. So we started putting up the written schedule for hand wash, for toilet training in the form of strips again. They were put up in the clinic washroom. The similar set was given to the mother also, and we would actually engage him in pretend play using the strips. So read and act. So open tap, the child would read, open the tap, put the hand wash. We actually had to do it. The pretend play was not like a typical pretend play that you would see, but read and kind of act out. Okay. And this actually helped the mother to get him independent in ADL, right? Because it's a big task, and the child was growing, and and he was always on the nappies, and it was really a big task for the mother. So, as I said, screen time was unavoidable because the mother was still going through her therapies, and of course, she also needed breaks in between, and the child also needed to be entertained the way he was entertained about. So, we introduced videos from the typical stories, and we started with the typical Gajapati Kulapati series. He used to be thrilled when the story would go on, but we had limited access to this particular thing, that he would see only the stories and he would not see any of these videos where there's a lot of gibberish going on. So we could actually stop that, and we could have a book open. So we bought the whole set of Gajapati Kulapati story. I would open the page, the child would listen to that, read the sentence in the scroll, and then we would relate it to that page and then turn the page. This was the way of me introducing him to some auditory language in the form of listening to somebody else's voice, which he avoided in completely. So he began doing on his own. He was thrilled with this particular thing, like listen to, read the scroll, see it in the book, and then turn the page. I don't like more than him, even I enjoy doing this. I had never done this before. So knowing the difficulty that you don't get every book in the print form, what you see in the YouTube videos, you don't get exact, because this child, I couldn't change even a word, not even a punctuation out there. So what we started doing is we would play a video. I would take the screenshots of each frame, print it out, and make it like a booklet form. So the child would have it there when he would listen to the story and do it. The mother actually was genius enough. She said that I would show him the screenshot and she would play it on the other device. So she would open that story on the YouTube on her laptop, and the child would have a screen which he would scroll, and he would do it very, very sincerely. He would not scroll till that particular image goes away from the screen. He was like so much into that. And that way he started actually narration. I would not say, I would just say from the memory, he would kind of say that whole thing. See, narration, I was like Dr. Namita presented, it has to be intentional. There has to be some purpose when you narrate something, right? This child would rattle it out on his own, like he would say the whole Gajapati Kulapati story while he's sitting idly. But I would still take it that he is using it to kind of probably, arrange it, kind of, put it in his long-term memory, or just to entertain himself, that he would start doing it. Next slide, please. Okay, so for his eating issue, like I said, he would not touch anything which was sticky and wet. So the OT definitely helped him improve with a lot of these kind of stuff. So he at least started tolerating things on his limbs, like of hands and legs. He would at least get into. This child would wear socks through like 24/7. He would not be off his socks. So the mother had that kind of a time, because it was very tough for her to kind of do it. So eventually the face was still a concern. He would not take anything which is sticky. He would not even allow a kind of washing face. So she had to still use the wet wipes and things like that. He would not rinse. Brushing was like a nightmare, as I said, for them. So as I said, numbers saved us again. We would have, I would write using the ketchup or cheese plate some numbers on the plate and have him lick it. So he would tell me 5, and I will write 5 with the ketchup, and he would lick it. Believe me, every lick I was jumping here, because we were going a step ahead, that this child was doing something which he has never done. Though with the help of numbers, we could get him to lick those things which were wet and sticky, which eventually he started eating. Then we would have a clean housey coin. We would kind of wash it thoroughly, kind of tape it at the bottom of the bowl and pour some soup, and then have him finish the kheer. And then he would be surprised to see a number. Then he wanted to go to the next bowl. So we would have to do this kind of. So we would have 2 or 3 bowls filled with either a soup or a porridge or some tea or something, just to see what is at the bottom. He would finish that off. And then now at least we are level where he eats khichdi, though not like very, very liquidified, but a little semi-solid consistency. Okay. So puzzles is something, puzzles is something this child would never really see. The Otis was onto this, that visual special is a thing that he can never see pictures, or probably we don't know how he processes the whole picture. So we started having, we made puzzles again for from the faces of his family members, first cut it into half, then make 4 pieces just to join them together, because this was the only thing that he was kind of used to doing, and he started kind of, I would not say enjoying, but he would at least participate to kind of satisfy me that okay, de diya hai to main complete kar dunga kind. We had come to that kind of a level of a rapport that because you're giving it to me, I will complete the task. I think that is a win-win situation for a therapist, right? He had started, to hum Hindi rhymes because, as I said, he was going to the play group and there he had an exposure. And he would sometimes enter the sessions, kind of humming it or actually kind of singing them aloud. So like we would use that, okay, now we want to sing, and that singing had to happen like singing. Okay, so we had to sit like this and sing to him. We cannot do this and sing to him, he would get disturbed probably. So there were no action songs happening. Probably in the school he had that exposure, but he had it that in the session we cannot have anything like going on. To literally fold my hands and sing to him, but that was the way. Okay, you want to sing now, but then we are going to put the screen away. So these were like the rewards that were given. So writing had begun to, and that was actually posing a big problem because the typical schools would always push the kids from junior KG, and then so doodling games, we encourage the mother to kind of start doodling. He would not hold a crayon or pencil for whatever reasons. He would not. He would just not do that. So we had some games where he had to doodle. Then we introduced the stylus, to use another instrument to scribble. He was okay with the finger, but then we had to use the stylus. Okay, and then doodle on the tab. Then doodle on the tab, then write on the paper. So that was like a sequence. So he would try and cooperate with that. Next session, next slide. So by the end of about 7 months of therapy, he could sit through a 45-minute session, allow 4 activities, and attend 2 therapies back to back. Had achieved good regulation, and looking beyond kind of compliance would help settling down with other therapies, and he would do that in school. And we had to introduce on and off screen games like spot the difference. We would give him kind of those printed sheets where he had to kind of spot the difference, and there he would use a lot of phrases, like I said, dog no tail, or elephant on not on tree, sun no blue. He would start coming, and these were spontaneous phases because we will keep changing the worksheets every day. And what's wrong was something that he would always kind of, and once in a way when he would see a genuine absurdity, like a sun blue, he found it very, very absurd. So he would have that little smile that, like, what is it? See, these tiny things I think are the best rewards for us, right? Next slide, please. So she needed, like I said, the scaffolding for the pillar, because when she used to be like he used to be in the sessions, she would get that me time. That was the only me time possible for her. We would actually allow her to like nap for some time or read a book. We have a clear instruction that the parents can't use mobile when they are waiting as far as possible unless they're handling some emergency. Most of the time parents kind of comply, I would say. And we actually started seeing a drastic change in her grooming. Like she would be, the history now, so she would not be really interested in doing, but we started seeing her, and she would come with a little smile on her face, and she would share her personal anxieties. She would come kind of have a chat with the other people around in the sessions and the room. And she had started on her online trading business, which she had completely stopped. She joined a yoga class. These were few things because she started, and we would always encourage her to do that. So next slide. So now he's gone back because they had stayed here for quite a long, and his dada dadi were really missing him, and they actually came and tried to convince me that they would really take a good care, because some point in the sessions we get so possessive with our kids, especially the pediatric therapist, that we don't want to give away to anybody, even to the parents. We have that kind of a thing. So actually they had to come and convince me that we would take good care and we would continue the sessions, though we are pushing them to have offline session locally available, but they're still kind of just Jan of 224, they kind of moved back to their place, and he still taking time to settle because it was a complete different set of people and the vicinity around. The mother needed to kind of settle back. things, and we have given everything that we made for him while he was with us. All the therapy materials that we had created, we have given everything. So he has some connect with what was happening even in a new place when he starts. And the mother has promised me that she would start offline sessions. Though he started attending online sessions with me now, but I'm still not. He was reluctant initially, right? So trying to convince her too. So this was my unconventional journey with AM and his mom. Thank you so much, Debo, for giving this opportunity. I think I just kind of took a little more time. I get passionate. Can't hear you. Can't hear you.
That is absolutely okay. The time is not an issue because I think we are here for our, our niche interest actually. So we don't have anything on the chat box yet, but I wanted to bring into focus a few things that you discussed, sort of summarize and what you put it. That you actually gave meaning and substance to the phrase or the well said phrase, that is, if you know one kid on the spectrum, you really know just one kid on the spectrum, because I think all of us present here are handling multiple children on the spectrum, and yet you demonstrated, you showed us something which I don't think many of us can say that, oh, we have done this. I don't think many of us can say that. So
Right.
if you see one kid on the spectrum, it is genuinely one kid on the spectrum. Then the part of the hyper focus on the numbers, and then when you connect it to the other issues like the textures, that then you cannot have the action song with the action, you have to sing like this. You actually understand how differentially the parts of his brain has developed, that he actually cannot tolerate you making those actions. He can tolerate you as a person around, but look at his sense of personal space, that you actually use the word, he was just tolerating me there. I was just there. So that kind of hyper focus, and you're combining his savant skill, that, let's use the number as a strength instead of forcing him to listen. I think that's what worked for this child. And um and uh, when we were younger, we would always put in a presentation, like, we put the first 3-4 sessions as rapport building and as connection and connecting with the child and all that. You put so much effort in explaining that part today. You really put so much effort in telling, in explaining the difficulty we usually face. I have faced a kid who was doing this, and it took us almost 3 weeks to figure out that it was the citrus smell of the phenyl, or of the cleaner, the tile cleaner, which was setting her off. There are so many of these things. Like, if you know one kid, it is really that one kid that you know. And talking at 3.5 years of age, another thing I would want to point out, many older kids on the spectrum today are able to talk it out and say that, I've always thought that you could listen what I was saying. I never understood I was not speaking. And there are moms who have reported that my child did not start with a word. My child just happened to say a full sentence. Can you pass that salad to me? And they were so shocked. The whole family was shocked. Oh my God, you just said a whole sentence. So from what you described, I just want to put around that, look at the presentation of a child on the spectrum and how different it could be within the spectrum. And we had Dr. Namita speak about differentially diagnose that the kid is not on the spectrum, and you work at something else on the semantic and the social aspect of it. So
Yeah,
if
it
you're
is
in touch
remote.
with this kid, I would really request you, if you on a long term, if you're in touch with this kid, when this child is able to talk, please ask him about these earlier experiences, because he will
I really
definitely
wish.
definitely put it up very differently to
Yeah.
us.
Yeah. So I actually would like to have him evaluated by a child psychiatrist also,
Huh.
because there is a possibility that he could, along with probably ASD, would also have intrauterine anxiety disorder, because the mother had 3 earlier failed IVF cycles. She was already getting beyond the average age of conception, so there are chances that he could have this intrauterine anxiety disorder, which is a known kind of
Huh.
a factor doctor, and probably whether when this child is going through neonatal depression. There have been cases where there have been
Yeah.
reported neonatal depression, failure to latch, because there was no failure to thrive actually. He was weak, but
Yes.
not like
Yes.
so weak, and he was given the best of the treatment from day one, because he fortunately comes
Correct.
from a very well-off family and they could provide everything to him. So I want him to get evaluated eventually, probably once he turns like 6 or something, where he could actually have a good tolerance to sit through a whole assessment, because a child
Okay.
psychiatrist would always like to go for something more observable in the session rather than just going by the
Yeah.
parental history, So
Correct.
I have already mentioned it to the mother that probably would need
Okay.
some, even the pharma would help him probably if he's
Correct.
getting some depression.
And also a psychologist, or why we should have the training in counseling, and why we should be, because you have the skill. I can, you can actually put it forth to our audience that you have to work at the skill, the language, the basic language skill of the child for the psychiatrist or the psychologist to be able to work, because
Definitely.
they don't understand, and they don't understand the dynamics of what we do to bring the child to the level where they can help, they can actually help basically. So
Mhm.
so another point that I really wanted to point out, because you said the relevance while you were talking about a story and the narrative, because that is something Namita ma'am covered as well, the dichotomy of the thought and the speech process. So I was just thinking about this, because when she showed those two videos, that look at the casual conversation, look at a social small talk conversation, and look at the picture, you understand the dichotomy of thought and speech so well, that and for that, the stimulation from home, the connection with your parents, your immediate family members, are so necessary that we take it for granted. If you listen to any psychiatrist talk, 6 is the age where a child will start hiding things, and they will understand, oh, if I tell this like this, at when my mom's mood is like this is going to be the outcome. I'm talking about a neurotypical kid, because
Mhm.
Namita ma'am specifically covered that these children don't have a history or a substrate, that they have some neurodivergent issues or a genetic condition, and these children were not able to develop a thought process. So when you were testing it through the means of speech, what you got was everything scattered all over the place. Whereas the case you described, it had a very good basis of language deficiency. There was an issue with development of language itself, and you could see that the constant interference of the sensory issues.
So,
So
yeah,
so
very well put. Mm.
so Namita ma'am, do you want to say anything? You're on mute. You're on mute. You can't wait a second. No,
Yeah.
even ha. Now
Now
you're.
you can hear me.
Yes,
Very
ma'am.
good presentation, Maitri. And yeah, the
Thank you. Thank
struggle
you.
was really evident from the way you were talking with the passion. Yeah, and there are a lot of such kids, and I just wanted to put, like, from there to getting to a semantic only issue is the
Yes.
key. Slowly, I hope what you are saying is at the 6, the child will come up with only those
Yeah,
issues, hopefully.
I just hope so.
Yeah,
Yeah.
yeah.
Thanks so
I
much.
think the common link you can see even in the kids that we are getting today is this 8 to 10 hours of screen that you're seeing. That is common all throughout. When you said that, I'm like, oh, I'm not the only one who was shocked when the parents said this. This is so commonplace, but at the same time, it exposes a very very dark side of human nature, that you were locked up. There was definitely a calamity. You were locked up. So this was a disease situation. At this particular time, there are so many war situations going on, and this uncovered such a dark reality of the human as parents. The one thing that you're tied to, the one thing for which you will put your own life online is your own kid, and in the history, the first thing is the parents facing, I know what we did was wrong, but there was 10 hours of screen ongoing. So
Mm.
Yeah.
See, that is how the brain
It's something.
processes it.
Sorry, Maitri, go ahead.
No, 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 no. Go ahead, please.
Yeah. So it's just that, because I have my younger child who was just born before pandemic. So people who knew to connect, those children have got the pandemic as the boon. Okay. Those parents who did not know how to connect, okay, who themselves probably were the adult version of ADHD,
Yes. Yes.
and they could
Yes.
not connect to the children, could not talk properly with the child, and could not have that bond, So those you can see the numbers are rising. Aware after 4 years when the child is not talking, still the child is not talking relevant. They are now coming up. So it had started in 2020. And now they're just coming up to the clinic is what I feel. The problem was right there. And the problem issue started in 2020. We are just now getting that, follow-up in the clinics now. That's all. So that is
Yes,
what
ma'am. That's why they have got
Yeah.
a bad name, na? COVID babies. The parents start with complaining ki, "Arey, we could not go to the garden," but then you realize what was happening at home. There was no play. There was no, because obviously, fine, there is one part of it that they were earning because they had to be on the system for that long and logged in and something like that. But then the other side, the dark side, was really this of humanity in general, not just this thing. And yes, ma'am, there are so many adults who actually have exaggerated versions, or the child has exaggerated versions of the gene they carry. So that is a reality.
Sure.
So thank you so much. And I would just share the screen for one little thing for you, for Maitri ma'am, just to see. And can you see the screen? And that is this. Thank you so much for accepting this. Thank you so much for discussing such small nitty-gritties. We grow in years by listening to you, by how to step back, how to reevaluate, how to think differently. So it makes a lot of sense to talk and discuss these. Thank you so much for giving your time on a Saturday evening. And we'll go back to our families. Thank you so much. We'll wind up now.
Thank you, Debo.
Thanks.
And great
Thank
initiative
you.
and great start.
And
Thank
thanks
you.
to the
Thank you.
audience who kind of been
Yes.
here too. Yeah.
Yes.
Thank you so much.
Thanks for the entire community support. Okay.
Bye.
Bye-bye.
Take care.